On behalf of Mamma Mia and patients today, I welcome you to our Congress reporting from SABCS. SABCS is the San Antonio Breast Cancer Conference, I would say the largest breast cancer conference in the world. And today I'm very happy to welcome Professor Marc Thill, who is reporting from about the newest findings in early breast cancer. Welcome on board. Marc, would you please introduce yourself?
Yes, Alex, thank you. So my name is Marc Thill. I'm heading a department of gynecology and gynecologic oncology in Frankfurt, of course, Germany, at the Agaplesion Markus Hospital. And for the reason that we are focusing on cancer, of course, I'm attending every year. And this was my 20th anniversary, Alex.
Wow.
I attended the San Antonio Breast Cancer Conference. And yeah, as you said, the largest breast cancer conference. So last year we had 10,000 attendees there. All right, so we are focusing in our first take on the BRCA mutation carriers. That means patients who are suffering from a mutation in BRCA1 and BRCA2 gene. This is a disclaimer, and these are my disclosures, so study cooperations and other things I do together with the industry. The first abstract we like to discuss, and Alex and me, we did our choice, our highlights regarding BRCA mutant carriers. The first one is a treatment study. The second one is about risk-reducing surgery. But let's start with a treatment study. So this is the OLYMPIA study, OLYMPIA study. So this is a study that led already to an approval for olaparib in the BRCA germline mutant patients, triple negative and hormone receptor positive. And I think you may be aware of that BRCA mutations can be found in all different breast cancer subtypes. The study was already published, as I said, led to an approval by the FDA and by the EMA, that means in the States, in Europe, and different other countries for the indication of olaparib in the field of breast cancer. And as I said, especially in BRCA1 and 2 germline mutant carriers. 1,800 patients had been recruited in the trial, and in the trial, the patients could be recruited in 2 different groups. So the neoadjuvant treated patients suffering from a non-PET CR, that means residual tumor in the axilla or in the breast for triple negative disease and hormone receptor positive disease, and in the adjuvant situation, triple negative with a tumor size of more than 2 centimeters or nodal involvement, and for the hormone receptor positive disease from 4 and more positive lymph nodes. You see patients having a BRCA mutation but being on a higher risk of recurrence. And these patients had been treated with chemotherapy, surgery, radiotherapy, and then in case of a BRCA1 or 2 mutation, patients could have had olaparib or nothing, placebo. So this is a randomized controlled, placebo-controlled trial. So as I said, we had already the study published showing a benefit, significant benefit for the event-free and for the overall survival. And this study was done to show what happens with a longer follow-up of these study regarding the patients. And you see here the patient's characteristics. So this is no surprise that we do see more BRCA1 than BRCA2 mutant carriers. We see that most of the patients are young, so they are premenopausal. And then the most of the patients were triple negative. Around 18% of the patients had then positive hormone receptor status. So this illustrates what we know. On one side, the 4-year invasive disease-free survival rate improved by 8.4%. And this is now new. So this was presented in San Antonio. What happens after 6 years? We do see a carryover effect. So the Kaplan-Meier curves you see are separating. And the benefit was increased by 1% up to 9.4%. So the yellow line are the patients having olaparib, the blue line, the placebo group. This forest plot, and Alex always says, so this is
difficult to analyze. I think they're easier graphs to read than the forest plot, but hey.
That's true. But this is like a little cupboard. So you have different shelves, and then you see different subgroups, and there's always of interest what happens on the left side of the dotted line. This is the one line, as we say, and everything that is on the left side is in favor for the use of olaparib, and there we see all the subgroups are placed on the left side. So therefore, there's no surprise.
Positive. Yeah.
And it's no surprise that we do see an improved invasive disease-free survival. I already told you that the overall survival was improved as well. So therefore, do we see this after 6 years? Yes, of course, we see the same situation. So another approval or another improvement, sorry, regarding overall survival and invasive disease survival. And this is the story. I mean, what happens after 1 year of olaparib in this high-risk population after 4 years and now after 6 years? And we do see that the benefit is maintained. And this is
which is it's incredible, because you only have 1 year of therapy, and then 5 years later you still have benefits.
Definitely. And of course, we do see less deaths and therefore, of course, and then reduced mortality, and then, of course, an improved overall survival. Alex, so this is something we always discuss. So how high is the price the patients have to pay for 1 year of olaparib? We do see that we see adverse events, but this table doesn't really illustrate the adverse events. So we know there's thrombocytopenia, there's anemia, and there's fatigue that is reduced or increased by olaparib. But here we see that we don't see any hematological malignancies regarding the use of olaparib. So this was one of the concerns. Are we able to extend olaparib for 1 year or 2 years? So we have 1 year because when the protocol was designed, my colleagues, they thought maybe we'll risk an increased number of acute myeloid leukemia, for example, and this is not the case. And we also cover ovarian cancer and other cancers, so the incidence is reduced by the use of olaparib.
It's positive, yes.
Definitely.
But there are other side effects.
Well, there are side effects, as you know, so thrombocytopenia, so the low platelet count, and then low hemoglobin levels. So this is something that really bothers the patients. Adds more fatigue to the fatigue syndrome that is there anyway after chemotherapy and radiation. So this is something. It's hard to cope with that.
Well, it is in a way you need to know what is my risk. So what am I gaining, and what is the price that I pay? I mean, if I afterwards are suffering from fatigue tremendously, then you have to take it into consideration. What's my quality of life if I choose to go this path?
Yes, of course. And therefore, we do see negative traits and positive traits. So this is definitely a positive. Family history, you don't need only a triple negative disease. You just need an indication, followed the data of the OLYMPIA study. So here we are having patients who had been tested or not known, but yeah, we are very happy that these are only happened in around 5% of the patients. So now we see the results. So what happened if the breast had been removed, and you see that this led to a benefit, an improvement of the overall survival significantly, I would say, because we see a benefit of around 35%, and the two curves, they're really separating quite nice. So this is something that adds more evidence to what we know. And here we see like not a really multivariate analysis, but we see that so what kind of subgroups benefited more than the others. And here we see that we don't see any differences regarding the subgroups. So every subgroup is benefiting from this risk-reducing removal of the mammary glands regarding overall survival. Other survival endpoints like disease-free survival and breast cancer-free interval are also influenced by the risk-reducing surgery significantly, with a benefit of, with an improvement of around 45%. But what happens if the ovaries and fallopian tubes had been removed regarding overall survival? Again, we see a substantial improvement of the overall survival when the ovaries had been removed. And here we do see little differences. So if I take the data for my daily business to perform a counseling for BRCA mutant carriers who are already affected by breast cancer, then I could say if I have a BRCA1 mutant carrier, these patients, they may benefit more from the removal of the ovaries. If I have a tumor subtype triple negative, they benefit more. But honestly, no one deserves to get ovarian cancer. So therefore,
yeah, I think it's the problem is that it's always detected too late, isn't it? And in an advanced stage, because there's no testing or no control on ovarian cancer. I think this is the scary thing. On the other hand, no ovaries, no pregnancies. It's something that there's a lot of factors that need to be taken into consideration before taking a decision like that.
Yeah, definitely. And these patients were very young, as I said, so 40 years and younger. When we take into account at what time we recommend to get a risk-reducing surgery, then regarding the breasts from an age of 25, but for BRCA1 mutant carriers, for the ovaries and fallopian tubes from an age of 35. And then sometimes you know that, I mean, then we do have patients in front of us and then they say, I don't have a boyfriend. You know, I'm not married. I don't have the man for my life. And now we're talking about the removal of the ovaries. So this is really scary. And this is a really, let's say, difficult talk. And then we have to talk about social freezing and all that stuff. So this is, as you said, so thank you for that comment. It really adds some value to our discussion here. Yeah, and we do see an influence on the risk reduction regarding breast cancer when the ovaries are removed. But as I said, and Alex, you just pointed out that ovarian cancer is a very bad disease, and so therefore, and it's not we're not able to perform a screening for these patients. So therefore, we recommend to get the ovaries and the fallopian tubes removed for every patient with all the problems we addressed already. So to conclude the study, yes, we do see benefits for overall survival and all the other survival endpoints for germline mutant positive trial, a real positive trial, because we add something to the overall survival. We add some benefit, and this is not so easy in early breast cancer. So therefore, I think this is another step, identifying patients where we are able to adjust our treatment. And this is great news. So it's not like one size fits all. So I think.
Well, at least, I mean, you have the big side effects that are not, there's no difference. There's very positive news. And then when it comes to fatigue, where we say, well, it's the risk, it's from case to case. You have to see what kind of therapies are there. It's a risk you take, but at least you know that this is what you're facing. And overall, yes, very positive results.
Yeah. Yeah, definitely. And this study, or this analysis of the study that was known before and published before, confirms the success of the study and the benefit for our patients. So therefore, nothing is changing. So we indicate olaparib in triple negative disease and hormone receptor positive disease when we do see residual tumor after neoadjuvant chemotherapy or in the adjuvant setting. If I have a tumor with a tumor size of more than 2 centimeters or nodal and triple negative disease, or if I have like 4 and more positive lymph nodes regarding hormone receptor positive breast cancer. All right. So as I said, so coming from treatment, so conservative treatment, systemic treatment, now to surgery. And we all know that if I am not affected with breast cancer, but I do have the BRCA1 and 2 gene alteration or mutation, then I'm benefiting by performing a risk-reducing mastectomy. That means the removal of both breasts or the removal of both ovaries. So this is what we know. But the question was always, if I have, so in case of breast cancer, I'm not able to, I don't like prophylactic, but in the end, if I'm healthy and I'm a BRCA mutation carrier, then I'm benefiting of the risk-reducing surgeries. But here are only patients summarized and analyzed who have already breast cancer, so who are affected. And this is a retrospective study we're talking about that was presented by my Italian colleague Lambertini, and you see quite a few patients. I mean, yeah, okay, it's retrospective, but in the end, more than 5,000 patients had been collected, and all of the patients were very young, so they all had an age of 40 and younger, and had a germline mutation of BRCA1 and BRCA2. So study design was very, very easy. Risk-reducing removal of both mammary glands, so breasts, yes or no, and then risk-reducing removal of the ovaries and fallopian tubes, yes or no. And the endpoint was survival. And I think, so this is again the very easy and very focused study design. And I think that we know since a couple of years that it really makes sense to remove the contralateral breast to gain over survival benefit, despite I have an affected other breast. So this was something a couple of years ago we didn't really know, and we said, well, removing the contralateral breast is not a good idea. But this is in the meantime we know that this really makes sense. So therefore, this is maybe not brand new news, but I think they add something to the body of evidence recommending, and if you do counseling with the patients, to recommend the risk-reducing surgery. So here we see how many patients suffered from BRCA1 and BRCA2 gene mutation. We do always see that we have more BRCA1 gene mutations when compared to BRCA2. Note positivity in more than around 50%, more triple negative when compared to hormone receptor positive disease. But it's very, very important. And this is something we had to highlight with the OLYMPIA study. So the first abstract we discussed that we have to increase our testing. So
Yes.
test, Alex.
Test.
Yeah. So this is very important to figure out that who is at risk having BRCA1 mutation, especially if you have olaparib. So you don't need any BRCA1 and 2 carriers, and it is very important. And this is what I added. So what does this mean for everyday treatment? That this information adds, of course, something for my daily counseling, and maybe I'm able to adjust and my counseling and to give some more distinct informations to my patients. I'm talking about risk-reducing surgeries. It's very important to test. So we have to say it again.
I think we can't say it often enough. This is only for the BRCA1 and 2 mutations. And it's so important to also, there are tests on genomics, genetics, get tested as much as you can, because it might change a lot in the therapy, in your life and everything. So yes, I think we can't remind often enough. But testing, testing, testing.
And what is also important, then you addressed this already. If patients come to my office and say, I want to have the best therapy, the best and the therapy where I'm having the best survival, then don't tell them that if they don't have a mutation, BRCA1 and 2 mutation, so get rid of your breasts. Because we're talking just of the breast, because patients sometimes they show up and then they say, I have no mutation, but I have an affected breast, I have breast cancer. Psychologically, I'm not able to cope with the situation, maybe get a contralateral tumor or get a recurrence in the breast. So this is something we have to discuss on a separate level. But if patients say, so what is the safest way that the cancer is not coming again, then it's not the mastectomy, it's not the removal of the breast, because we do see and we do have a lot of data, and this body of evidence is definitely growing, that breast conserving surgery will lead to a better overall survival when compared to
mastectomy, which is very surprising. But it's good that there's data there, because from psychological point of view, it would make sense to say, like, okay, well, I had breast cancer, take it away. I want to get rid of my breasts. It's maybe a natural reaction, and maybe data can then help to say, well, that's not always a benefit. It's a big operation as well.
Yeah, that's it. And this is good for counseling as well. Yeah.
Yeah.
Just to add this information, has nothing to do with BRCA, but just with mastectomy. But
okay, well, that's very positive. Thank you very much for taking the time to discuss the newest findings from the SABCS with us.